we are not yet there. So we need to look at the residual poor outcomes. We need to look at the costs, don't forget the costs, and also build the population's confidence. So I'll end with this statement, which is also in the Lancet Global Commission. We will know that we have high quality health systems when we in this room all choose to receive health care in our own health facilities. If you have a DHO who goes for care in Kampala and leaves the health facilities in their district, then know yourself, even if you don't have data, just know that you don't have a high quality health system in your district. Therefore, we still have a lot of work to do. Thank you.
Thank you so much, Dr. Esther, for that very, very questioning presentation, questioning really our systems, whether they can deliver the better health and whether people have the confidence in it and producing the economic benefits. Members, I'm constrained in terms of time because I think we are going towards 11, but we are going to try to move very fast so that by 11 we are through with this. I know the presentations, the keynote address there, I know you have so many questions around there. Even now, Esther brings in this perspective of whether we are able to save the people. Are we designing systems to save people, or we are saying, no, if 50% die, then our system is fairly okay. So all this, I'll invite Prof. and Dr. Esther. We take a seat here and we receive the questions. I also request our timekeeper, you should keep alerting us. I'll need to use not more than 20 minutes for the discussion. And I will start with the people who are on virtual. And please check the IT team, check if there is someone there ready with a question. Then we shall come back to the audience here. And I say we shall need, I think, average of 3 persons for the presenters, maybe the keynote 5, then 3 for Dr. Esther. Thank you. So now people on the virtual, I need information if there is a hand there. I'm not able to. None so far. Okay. Back here in the plenary, please. Your hands. Let me count the hands. 1, 2, 3. So let's start from the first here, then the second, then we come to the third, the fourth can see there. We have 2 there, that is 5, 6, 7, 8.
One for a comment for Professor. It may be one for Dr. Karamaji. The beginning with the Professor, I think is not to him, it's maybe to us. He has gone through a lot of innovations And many things seems to be working because of those innovations. Maybe this is a soul-searching presentation for us to answer the question, how much space do we give our people to innovate, to come with ideas outside the box? I have been in this system for the last 25 years, and I know how restrictive it can be when it comes to us making innovations. Dr. Karamaji, thank you for that. I think it also comes to the cry of how much are we putting in to innovate. My attention was drawn to your presentation on some inefficiency of service delivery in some areas to demonstrate how high quality service delivery can occur using this system. However, when you are dealing with the inefficiency issues, you showed us how low some facilities are performing. I thought if we reach that point, you'd also go an extra mile and tell us the little that we are doing, what resources are we using it, especially monetary, so that we know how much unit is produced per, how much is produced per unit cost. Thank you.
Yeah, thank you very much, presenters. Richard Joko is my name, and I work with Baylor, Uganda. My question goes to Dr. Esther, and thank you so much for this very powerful presentation for redesigning the healthcare system. And we really see that there is quite a lot that is really going wrong. And one of the comments in the redesign is looking at the political engagement that you really didn't redress so much well. So my thinking is that, do you have an opportunity, or have you planned out a session to deal with the technical working groups of Minister of Health and the political heads to try and then share this very presentation, because they are solely responsible for resource allocation, but then also guiding processes of the technical and competent support supervisions across all these health sector designs. Thank you.
Good. Yes, I think, yes.
Thank you, Chair, and thank you, presenters, for the very insightful presentations this morning. One for Dr. Esther. Given the complexity of the systems that we have and our communities are part of the systems, what would the roadmap for redesign, if we wanted to do that, what would it look like given what we need to do? Thank you. And then for Professor, thank you very much for reminding us that we all have the potential to innovate, but also you highlighted the fact that if we innovate and we don't document, it kind of passes by, even if the innovation is taken on. So for all of us in the room, we all have the potential. I think he also reminded me of some of the things I've done, but have not documented. But I think let's go out and solve problems and think creatively and be bold and be intentional. But also it requires us to be exposed either through reading or through really inquiry. Thank you very much.
Thank you so much. I'm called Dorothy from MJAB Kampala. My question goes to Dr. Esther. I'm kindly inquiring if the quality improvement could also begin from the Ministry of Health itself. For example, when I look at the issues of supply chain, sometimes you're given drugs and they're like, it's an order from the ministry, even if it is short-dated, you have to issue it out. So it somehow affects patient care. for example, MMD. So I was kindly inquiring if you could consider quality improvement, starting from the Ministry of Health itself. Thank you.
Thank you. The sixth.
Thank you very much to our presenters. I have two questions, and the other is one question and a clarity. The question, I'm Luciana Chiega Wamala from Macquarie University Walter Reed Project. The question to Dr. Esther, I looked at the visual regarding feedback on people's voices, and I was looking at the y-axis. I think that was the net growth, and then we had the x-axis. I think it was either the number of people that were responding. I just needed clarity. The round visuals that we were seeing, was that a geographical representation or an increase? Was it the different regions that were responding? And then the other, you were showing us some of the different ways to know, and we're looking at, I was captivated by the perinatal deaths and focusing on Uganda. I saw that perinatal deaths among low-risk mothers were at about 57%. When I looked at the absolute numbers, I was trying to do a calculation, and I equally realized they are actually less in high-risk mothers. Just to clarify, is that so? And if it is so, why is it that they are more in low-risk mothers? Well, I was trying to think it could be because of the inadequate care, but I think it would be good to also hear your take on that, seeing that they were, while I was just calculating, they were seemingly more. Thank you.
Yeah, so thank you. My name is Dr. Jennifer Adong, and my question is directed to still Dr. Esther. Looking at the options of financing, and in Uganda we have the option of health insurance that is coming up. But when we look at the population of Uganda, the highest is peasants, and that most of the agricultural products don't have taxes on, or unless there's a middleman who has taken on from the peasant. How best can a country like Uganda, which has a fewer percentage of its population directly under government scales and taxes, how best can they strengthen the health financing system to support its country's health system? Thank you.
There were 8. So where's the 8th? The 8th one is the last.
Yeah, thank you, Chair. I'm Eunice from Kamuli District Hospital. Mine goes to, first of all, I want to thank the presenters, Professor and Dr. Esther, but mine goes to Dr. Esther still. Yeah, as she was presenting on redesigning our health systems, I think there is one cancer that has eaten us as health workers, much as we would love to offer quality services, but we have a cancer of poor attitude towards our duty coverage, whereby you may think that in a primary level, health workers must be there and attend to the clients, but you find that the organized absenteeism is still a challenge, and attitude towards work coverage. What are we going to do? Because this goes right from ministry up to the peripheral levels. Thank you.
Yes. Thank you. We have another one.
Yes. Thank you, the presenters. Jessica from Lango. My question goes to Dr. Esther. Thank you about the presentation on redesigning. My concern is at what level is this redesigning thought through? What is in place to support the redesign since there's some kind of work done? Then there are steps, and what are the priority? The whole system seems to be big, but what are the priorities for the start? Also, I've noted that many things happen at the lower facility that improve the quality of care, but many times they stop at that level. Are there any kind of support that can be given to these people? I see that some kind of currently something to do with client-centered metrics for the clients, but these are done at facility level. So if you're thinking of redesigning, are we starting at different levels, or and then there are also priorities?
Thank you. Thank you. Thank you. We need to turn back this way because of time constraint. We are just going to have quick responses. And Esther, you have had many, but I think you will package them into, you will know how to make it within a few minutes. Let me ask Prof to respond first, then Esther.
Thank you. Thank you so much. Thank you for the question and comment. First of all, I want to mention that we have to have a mindset to connect macro issue and micro issue in our mindset, because the healthcare for the respective patient, it's a macro issue for their lives, not for the issue for the entire country, for them. Preventive deaths should be prevented for each patient. Their lives is a macro issue for them. So Dr. Esther has successfully summarized what we have recognized as a macro issue, and including the financial health financing mechanism. But from my point of view, each hospital is an independent organization, even though all government health facilities belonging to the country. Each health institute, health facility should have a certain efforts to uplift safety and quality to prevent preventable death. It's very obvious. From this point of view, I admire a lot of efforts has been done in different types of hospital with the leadership of the top management of the hospital, and then middle class managers, and then on the ground the people are working very hard. I recognize the shortage of the nursing officers, for example, even though we can't stop providing service. Based on that kind of understanding, I can say that I have to tell you that there are potentiality of the frugal innovation creation from the staff, even at the ground level. For that particular purpose, we need a certain training on them. The training could be done automatically in their routine works. The most convenient measure to improve the sensitivity of the staff is a work environment improvement, as we are working for a long time. 5S activity gives you a hint or a tip for innovation. Then, of course, based on those experiences, different types of human resources in the hospital should be further trained for problem solving. Through those activities, definitely some of them definitely have a good idea. Then there is an opportunity to take up those ideas by the top management of the hospital or a quality improvement team. Those mechanism is quite important. If we strengthen those activities horizontally throughout the organization, definitely we will have opportunity to see innovation. I have seen some already in some hospitals in 18 out of 18 different regional referral hospitals. We have to trust them, and then we train them. Thank you so much.
Thank you. Thank you, Prof, for that. Let's have Dr. Esther.
Okay, thank you. I will try to be fast. In general, I think I heavily agree that in Uganda we depend a lot on the ministry to develop and send down innovations. We really need to break out of that. That's not how other countries operate. Districts, regions, and so on are the source of innovations in some cases, in many cases, and you can redesign at your health facility, at your district. A district by itself can redesign if they decide they can redesign, and our ministry is very open to picking lessons and encouraging your learning from you and going to scale. So we need to break that. That's in general. And also I'd like to say that the SCAP department has started on what we are calling the People's Voice Survey. This will give you this type of data for Uganda, and it speaks to politicians because there have been a few questions on politics. These people are voters, so what you're going to tell the politicians, this is what your voters are saying about healthcare. So we will have at least data that every district, every facility, every region can use to engage politicians. And I know someone said, what about the politicians within the ministry? And again, that's being started. That's where we are starting from, and this speaks a bit to Kenneth's question, what's the roadmap? We first have to sort of understand how to look at the data we have so that we can speak for what we can see. There are some things you can see, but people don't believe you. You really need to pull data. Dr. Nyeko, I agree we should have looked at how much is produced per unit cost. I think you should be able to see that in the national health accounts. It's where I got all the costing data that I showed you. Dorothy of MJAP, MOH should work on drug shortages and so on. Please, I hope you can find someone from MOH to ask about that. I agree with you. Lucia, the big circles were the size of the company. The bigger it is, the bigger the people who are in that industry, the bigger the size. And it is true that perinatal deaths now may be more in low-risk mothers than they are in high-risk mothers. That's depends how you look at it. For me, it's a good thing because we've focused a lot on high-risk mothers and reduced the deaths. Even the maternal deaths now are lower, you know, in high-risk mothers. That's what we've been doing. We've not been wasting time. That was good effort. What we are saying is, are we ready to take it to the next level now? And we shouldn't drop that work or those innovations, and we shouldn't stop them. They are very important because they've at least taken our maternal mortality down to a very good number. Health insurance, health financing, what I see in other countries is a mixed bag. They don't pick one approach and say, okay, from today it will be government financing all healthcare from now on. They mix things according to what works. I have seen, at least even in the US, a hospital can get money from the government if they give them certain data which they ask for, evidence that they have a certain minimum quality standard, they can get money. Then there's the money they get whether or not they do those things. And then there's the money they get from insurance. It's usually not a mixed bag, but I know we have experts in the country for that, and we should remain interested as people in quality in that conversation. And absenteeism, again, I hope you will find someone from the ministry to ask about that. At what level do we, I don't have a plan written out that for Uganda, this is how we are going to redesign or to achieve high quality health, but I know we have experts from the facility, regions, districts, and committees and all these structures that we can go to and discuss and together come up with a roadmap that works for us, a system that works for us. Thank you.
Yeah. Thank you so much, our presenters. Let us give them a round of applause. Good. This session has ended, but the question on absenteeism, I think the Director of Governance and Regulation will comment on it at a later date. Thank you so much.
Before session chair you leave, there is a comment on the online. Maybe you could read it to sum up your session.
Good. This side I'm not able to see well.
Okay. It's a comment from Albert Rachimali. He says, one of my pains about MOH and other government departments, they are extremely wasteful. Most times every stakeholder is focusing in towns and cities. What funding opportunities with minimal bureaucratic are there for health workers who have innovated and would like to scale their innovations to support the lower place communities? And then this is either Professor or Dr. Esther to answer. But of course, the question that has ended, but this is Rachimali online. The director has taken note, and it will be responded to in the subsequent presentation. Now, dear delegates and colleagues, allow me to join our hands once again to give this team a round of applause. They have made our money. And to Professor Handa, arigato gozaimasu. Yeah. So please, Dr. Esther, thank you so much. And Director Joseph, of course, when we reach, we are going now for break tea. You will read our keynote address to where we are going to have break. So it's break time. And what is going to happen after break? We are going for the breakout sessions. Like I said, I'm sure everybody has already been perusing through the program book to determine which breakout session you're going to attend. So we have in Ziba Hall, it will be on improved service delivery models, and the chairperson will be Alfonso Quizera, who will be here. And in Alfonso, I hope you are around. Yes, great. And then from Kama Hall, they will be looking at all the thematic area there is special groups and health management information system, HMIS, and Dr. Simon Momuza. Simon, by show of hands. Okay, I hope he's around. You will be the one chairing that session. So let's go for break tea. The time check is approaching. It's 13 minutes past 11. Maybe let's say 11:15, and let's make sure that at 11:40 we are back in the respective breakout sessions to kickstart immediately. Thank you, bon appetit, and a good morning once again.
Yeah, may I request the session chairs and the presenters, please make sure that you are the first ones to have a cup of tea and a bite so that you are back to kickstart the next session. Thank you. So if you know that you're a presenter, either in Ziba or Kama, please make sure that you get your cup of tea, coffee, well in time, and then you come and prepare for the session. Thank you. Okay, welcome back from break tea. Like I said, I know the poster presentations become a bit too engaging and then we forget the sessions we are supposed to attend. Please, we are having 2 breakaway sessions. And I'm requesting, members, I'm requesting for your attention. Poster presenters, please leave the posters so that we can embark on the next session. Even those of you who are visiting the posters, please, let's come together and follow the next presentation. Here we are going to have the thematic area which we are following will be improved service delivery models. That is what is going to be, the presentations that are going to be discussed will be in this hall, Ziba. Then in Kama Hall, the other way across, please members don't forget to go to Kama Hall. I'm seeing, because I'm getting reports, people maybe they are becoming a bit lazy or for some other reasons are not going. Please also let some members also go to the other presentation, and the thematic area is special groups and health management systems. So they are already waiting. They have around, is it 9 presentations? So we need also, it's also exciting there. So here we also have a similar number. And I want to invite the session chair, but I'm finding a problem with the poster presentation. Please, can we leave the poster presentations alone? The presenters, please, it will be after lunch. And since we are all adults of sound mind, I wouldn't like to point fingers and come and just tell you leave, because we can't have 2 sessions going on at the same time. The poster presenters, please, just stop there, you resume. In case you are nearby there, just let them know that please, let's leave the business here to start. So good morning once again. I hope you have enjoyed the health break. Allow me invite the session chair for this session. But before I do so, let me make some roll call of the presenters. Dr. Eseri Brian Atubu, are you around? Please, can you come and take your seat here on this table, the front table? Muruoza Jude, please come forward. Irene Nachirija, Irene. I don't. Yes, please. Just take your seat here. You can come with your laptop and whatever. Yeah, that front seat. You utilize it. Then Imelda Asingura. Yes, Ime, please. Yeah, just move because you are very important for this session. And the session chair needs to be comfortable that you are within sight. Like I've mentioned, please move. Helen Nandudu. Helen? Where's Helen? Yeah, Helen Nandudu, are you around or we can answer you? Because we need to assemble the presentation. That's why I'm doing this roll call. Please. Noeline Mulangira Sanyu. No, Noeline? Yes, please. Okay, since you are seated there, that's fine. But be on the front panel because the session chair needs to see his people. Then we have Rita Namusi. Rita, please come forward. So these 2 tables. Rita? Okay, carry on behind, carry, no problem. Henry Matende. Henry? You went to Kama? Oh, okay, then maybe it was a typo. Edgar Tusubira. Just take the front, even if you're on this front seat. And Jennifer Adong. Yeah, okay, come forward because we need to. So the only person, session chair, Alphonse, just take note that Matende Henry is not part of your. Eh? Eh? Eh, so you are here. So you have, let me just say, because 1, 2, 6, 7, 8, 9, 10. So, session chair, you just sit on that. So there are 10 presenters. You need to balance the time and, oh. So I'm taking some bit of time because we need to be on the same footing with the session chair. It's coming to noon. Okay, I'll just assume that from up to 1, you have 1 hour to settle in, 1 hour and 10 minutes to settle in. So ladies and gentlemen, let's join hands to welcome Mr. Alphonse Kwezera of LHS Ankole region, who is going to be the session chair and to take us in this thematic area of improved service delivery models. So Alphonse, you're most welcome.
Thank you.
Yeah.
Thank you, MC. Good morning. It is still morning. Good morning, all of you. You are most welcome to this session, and I'm glad to be your session chair for this particular session on improved service delivery models. Improved service delivery models is going to be an interesting session because it particularly touches innovations that are being implemented and different models that are being tried out in health facilities at our districts and regional level to improve services. So I want to welcome you. My name is Alphonse Kwezera, and I am the manager for quality improvement and knowledge management at the USAID Local Partner Health Services Ankole and Acholi activity. And I'm based in the Ankole arm, and that activity is implemented by TASO on behalf of USAID. It is implemented in 12 districts in Ankole and 9 districts in Acholi, and it seeks to improve health outcomes, increase uptake to services for comprehensive HIV service delivery for the populations in Acholi and Ankole regions of Uganda. So that is briefly about me, and I would like to straight away guide that each presenter is going to use 10 minutes. I want to think that the IT team has uploaded the presentations, and we shall follow the order as outlined in the program book. And whoever finishes to present, you take up the podium. 10 presenters are quite many. I would think that it would be better to probably break it into 2. If we can have probably the first 5 or 6 take up the seats here, and then we shall move to the next group. So without any further ado, allow me invite Dr. Esere Brian Atubu. Brian is going to speak to us about increasing tuberculosis case identification through contact tracing. I think this is at TASO Center of Excellence in Tororo District. You're welcome. Please welcome him. You can take up the floor. Thank you.
Good morning. Yes, so that is me. I work with TASO Tororo. And next slide. Okay. Yes, so Tasso Tororo, at the time we started this documenting our work on TB, we had 8,100 clients in our care, and largely our diagnosis is when they come for a clinical encounter, you screen, symptom screen, identify TB, and then enroll that client to care. However, for that period, October 2022 to September 2023, we received a target for 255 cases, and we thought we needed to be more innovative to find TB cases. And so we set out to be to more actively do TB contact tracing. So we started with a learning session for all the staff at the facility, and the purpose was so we can identify the symptoms. Importantly, every person who had a positive symptom screen had a sputum sample taken. For the PBC cases, we had to do contact tracing, and that was done within a week. So initiate the client, and within a week go to their home and identify the contacts, close contacts. In that picture we can see something like what happened. This was a small village in Tororo. So every contact who had a positive symptom screen would initiate them on treatment, but also take their sample for gene experts. The contacts that had no that had a negative symptom screen would give them TB preventive therapy. This is what we had. By September 2023, we had identified 293 TB cases. Of those, 223 were PBC cases. Of the 223, we had done contact tracing for 210. And from their contacts, we were able to identify 153. 153 of the contacts were diagnosed with TB and started on treatment. We also had those categories initiated on TB preventive therapy. So from this, we learned that if you did TB contact tracing aggressively, like we did emphasize, it is a targeted way of TB case identification. It is easy, it is cheaper, and it's doable, really, if everyone at the facility is on board and people are intentional in doing contact tracing. Contact tracing is known to all of us here, and everyone who treats TB clients knows that they need to do this. But the purpose of this was to show you that there is great success you can get if you're very, very intentional in doing this. And so at the end of the year, we were able to achieve our target. We had 45 cases more on top of the 255 earlier target that we had received. But importantly, we also had initiated many people. I didn't show you that, but close to 608 individuals benefited from TB preventive therapy. So this is known to all of us. Just practicing it, like in our country, but not during the COVID time, there was aggressive tracing of contacts. And personally, I believe if we are going to help reduce TB, it doesn't really help treating only those who present to you, but being very aggressive in identifying their contacts and treating them too will help us decrease TB in our community. Like I said, it is a cheap and sustainable method as long as we are extremely intentional on doing contact tracing. It also helps with quick identification of cases and helps us control disease spread in a shorter time. Thank you. Those are the, of course, I acknowledge the team I work with at TASO and UPMB that do technical support, the implementing partners, and TASO Uganda management. Thank you.
Thank you. You can take up your seat. Feel free to sit anywhere. So that's Brian sharing with us experiences on contact tracing. Let's invite Jude. Jude, or a representative of Jude. So Jude is going to speak to us about strengthening quality of referrals to improve outcomes. Lessons from Mbale Regional Referral Hospital. You will tell us which referrals those are, because here it's not well described. Take the floor. You have 10 minutes. Thank you.
Thank you, Chair. Good afternoon, colleagues. Presentation, please. I'm Dr. Mloza Jude. I work at Mbale Regional Referral Hospital as a consultant officer and guide, and I'm here to share with you some interesting work that we've been doing with my team. Basically, it's about sharing the effectiveness of strengthening the quality of referrals that come in at the Regional Referral Hospital. So we've done this work with co-authors. We have Esther Nambala, we have Martin Mogisha, we have all those other colleagues from UHA. Next slide. So as a background, Mbale Regional Referral Hospital has the widest catchment area in the country with about 16 districts and 1 city, and this covers a population of about 4.5 million people. Next slide. And with that background, this hospital is expected to provide specialized services to the population. However, this has not been the case. As you notice that we have been having a big number of referrals from the region, and at baseline we had about 6,000 referrals in 1 quarter, and when you look at these referrals, we realize that these are referrals. They are mainly mothers and newborns, but unfortunately these are referrals that could be handled at lower level facilities if these were well functioning. Of course, such referrals are costly to the health system, and they result in delay in providing appropriate care, contributing to poor outcomes. So we set out with our IPs an activity to see how we could address the issue of inappropriate referrals to the hospital. Next slide. So we looked at our referrals from our register, and we did the root cause analysis of the key factors, and we discovered that some of the reasons for referrals were limited data use, poor attitude of health workers, organized absenteeism, but also lack of skills. These were mainly the issues around the referrals that we are receiving. So we set out to do various activities to address this. And one of the activities was to organize performance review meetings focusing on RMNCAH. And these meetings were attended by key stakeholders from the region, that is to say the ADHOs, the DHOs, biostats, and the in-charges of health facilities. So during the reviews, we would discuss, of course, the performance, the gaps, and also agree on how to address the gaps. The other activity we did was to identify the facilities that we are referring, what we refer to as inappropriate referrals. After identifying them, we would attach medical officers from these facilities to the regional referral hospital for a period of 2 weeks. And during the attachment, the medical officers would work with the specialists, pick some knowledge, pick skills, but also issues to do with attitude would be addressed. And following the attachment, the medical officers are followed up at their places of work. The third intervention was the technical support supervision groups that were done by a multidisciplinary team from the regional referral hospital to go and support health workers from the different areas. So this was looking now beyond MCH. It was looking also at the other areas of care. We also created a social platform where our colleagues would be able to consult specialists and other providers, to consult about care of patients, but also to consult about the needs that they had that would prompt referrals to the regional referral hospital. And only a referral would be allowed only if that need cannot be addressed. For example, if the reason for referral is blood, we actually try to get a way of sending blood to the facility instead of letting the patient who needs blood to come to the regional referral hospital, because it is cheaper to send a commodity than to transfer a patient. And of course, we agreed that before you send out a referral, make sure you communicate so that we agree on whether that referral should be executed, and if so, the regional referral hospital prepares better to handle that referral. Next slide. And as you can see, the results are amazing. We had a baseline number of referrals of about 6,000 at baseline in the first quarter of 2023/24, and this reduced by more than 50% in a period of about 6-8 months. Next slide. So we noticed that reduction, and specifically there is a partial hospital that used to refer most, and this is Parisa General Hospital, and this registered the biggest reduction in the number of referrals to Mbai Regional Referral Hospital. And the lessons learned, we realized that discussions with the facility and the district leadership teams to generate workable solutions can improve service delivery at different levels of care. But also follow-up visits of the mentored health workers are able to cause improvement in skills, but also in service delivery at specific sites. Then creating channels of direct communication between the providers at the lower levels and those at the regional referral hospital would also curb the issue of inappropriate referrals. Next slide. So the recommendations, there is need to continuously track referrals so as to identify the facilities which are having problems. And there is need to have regular interactions between the regional referral hospital and the lower facilities. But also there is need to have the contacts of the key persons at the regional referral hospital shared with all the members within the region so that communication is better. And in conclusion, stronger leadership and coordination with the district government and the regional referral hospital can play a great role in improving the skills of the workforce in the region, the lower level facilities. There is need to strengthen collaboration with districts to ensure the quality of maternal and newborn health services. I acknowledge. Next slide. Before that, these are some of the pictures of the work that we've been doing. In the top left, you can see a team from the Regional Referral Hospital reaching out to one of the center force, that is Bugobero. The next, where you see people putting on theater things, we see a team of specialists working with the medical officers from the lower level facilities, but at the Regional Referral Hospital, passing on some skills. And then the picture with many there, we have a stakeholders meeting where we have DHOs, ADHOs, facility in charges, and the team from Regional Referral Hospital discussing the issues about maternal and newborn health. And lastly, there's a photo of the most recent group of medical officers who were attached at the Regional Referral Hospital with 2 specialists. That marks the end. Thank you so much.
Wow. Wow, that's so good, Dr. Jude. Kindly take the floor here. Please, a round of applause. Those are interesting. That's an interesting work from the Regional Referral Hospital. You have actually demonstrated that regional referral hospitals can still take charge of the regions. That's taking charge of the region. You follow up, you understand the issues, and you work with the districts and lower facilities to address those issues. Thank you for those experiences from Mbale Regional Referral Hospital. So we move forward to Irene. Please welcome Irene. Irene is going to speak to us about increasing postpartum family planning uptake as an integral part of care along the MCH continuum of care across 11 FPA implementing districts. You tell us what FPA is. Thank you.
Yeah, thank you so much, the session chair. My name is Irene once again, and on behalf of the team, I'll be taking you through our experience at the family planning activity, how we have implemented and increased the uptake of postpartum family planning, not as a standalone, but as an integral part of the maternal and child health continuum across the 11 implementing districts. Next slide, please. The next slide, that slide talks briefly about the FPA. And FPA is a Pathfinder Uganda implemented activity that is funded by the USAID. It's a 5-year initiative whose goal is to increase the adoption of the positive reproductive health behaviors and practices. It has 3 intermediate result areas, one focusing on leadership and coordination, the other focusing on addressing the social and those cultural norms that really hinder uptake of family planning services. And number 3 is the access to increased or quality voluntary family planning services. This activity is implemented in 11 districts across the country. They're highlighted in purple. And it's covering 219 health facilities. Out of the 219, 10% are hospitals and health center 4s, the rest being health center 3s and health center 2. Next slide, please. Yeah, back to the family planning content. Family planning, you'll agree with me, it's a key life-saving intervention for mothers and children, and it's the #1 pillar for safe motherhood. Postpartum family planning itself plays a critical role in strategies to reduce the unmet need for family planning. The postpartum period, which is 0 to 12 months after childbirth, is a unique opportunity that addresses the unmet need for voluntary family planning. Yet, the service uptake remains low, especially in that immediate period that is 0 to 48 hours or before discharge of the mother. Many times, this leads to unintended pregnancies, given the fact that return to sexual intercourse differs across the different regions. And it's most likely leading to these unintended pregnancies and thus leading to the poor maternal and child health outcomes. You will agree with me that closely spaced pregnancies that take place within a space of 1 year really poses a health risk to the baby and the mother. So as FPA, the family planning activity, we have demonstrated progress in implementing postpartum family planning, which is significant, especially between 0 to 48 hours, 6 weeks. However, we also see the greatest change of 80% beyond, between 6 weeks and 6 months. Next slide, please. Yeah, in October 2021, the family planning activity, through its routine assessment and service available data, we were able to identify leakages in the provision of postpartum family planning services along the continuum of MCH. To us, these were considered as opportunities to strengthen the uptake of postpartum family planning. As FPA, we facilitated the integration of postpartum family planning into the robust immunization at facility and through outreaches. We also supported, out of the 219, we supported 77 health facilities to initiate the CQI projects with the aim of improving postpartum family planning uptake. Again, we facilitated the facility community referrals. Those are from facility to community and back to facility, as well as ensuring that there is great access to the short-term methods even at the community level. Next slide, please. Yeah, that is a summary of the approaches that we have implemented at the health facility. We have made sure that health workers are skilled. We have made sure that counseling for postpartum family planning and health education takes place. We have made sure that services are available, having commodities available, having focal persons available, as well as capturing data. At the community level, we've also ensured that there is good demand generation for family planning. We have come up with a package for postpartum family planning service delivery at the community level, as well as the linkages and referrals back to facility. Next slide, please. Those are our results. 460,858 mothers attended postnatal for that period, and 53% of these mothers that attended postnatal received a postpartum family planning service. And out of these 53, a great number contributed to the entire family planning users. 28% of these were postpartum mothers. Next slide, please. Yeah, we also tried to bring out a correlation with other MCH indicators like antenatal deliveries. You agree with me that during the baseline, the postpartum family planning indicators were at the lowest. But by the end of last year, in 2023, we see that the postpartum family planning timing and by method were almost at the same level or even surpassing other MCH indicators. When we look at the other slide on the disaggregating the timing, we realize that our bar for immediate postpartum family planning has continued to increase. And for the period 2023, that was for only 6 months. So I am sure data up to December shows a different picture, a better picture. Next slide. All we are saying is that really there is an increased number of women attending ANC and delivery from the health facility. You'll agree with me that it is the same even in the UDHS report 2022. So what does that mean to us? To us, it gives us an increased opportunity of client-provider interactions for mothers and couples that are accessing MCH services, both at the community and the facility, thus leading to an increased chance for us to initiate postpartum family planning discussions with these mothers and couples. Next slide, please. Yeah, all we are learning is that initiating postpartum family planning discussion with mothers and couples during these MCH services increases their chances of choosing an FP method of their choice. And in conclusion, we are saying that promoting postpartum family planning as an integral part of the existing MCH and FP efforts helps to close these gaps and leakages, and thus increasing uptake of postpartum family planning to mothers. Last slide, please. Yeah, those are our recommendations that are really scaling up our community interventions like dialogues, radio talk shows, and drama reaches saturation with community information on postpartum FP. Intensified counseling is very key, commodity security, QI initiatives, and the entire health facility approach. Thank you so much.
Thank you. A round of applause for Irene. Thank you for sharing with us those approaches to increase family planning uptake from FPA. Thank you, and please take up your seat here. Let's have the next presenter, Imelda. A round of applause for Imelda as she comes. We just had breakfast. I think those claps are not enough, colleagues. Thank you. So we are going to have Imelda speak to us about improving hemoglobin estimation for pregnant women attending first ANC at Kabale Regional Referral Hospital. And please use the gadget for changing the slides. There is one there, yes. You can always use it to...
I'm from Kabale, I don't know how to...
You are from Kabale.
Yes, good afternoon, ladies and gentlemen.
Thank you, proceed.
I'm Imelda Asingura. I work with Kabale Regional Referral Hospital, Kabale District, southwestern Uganda. I'm talking about improving hemoglobin estimation for pregnant women attending first antenatal at Kabale Regional Referral Hospital. Yes, you agree with me that hemoglobin estimation is one of the key quality of care cornerstones to a safe motherhood. And it is a measure of levels of anemia. This anemia, when they take your hemoglobin and I find your hemoglobin is low, we say the condition is anemia. And therefore this anemia in pregnant mothers, it increases or exposes them with their newborn fetus to a greater chances of developing illness or death. Severe iron deficiency anemia in pregnant mothers has been associated with increased risk of stillbirth, low birth weight, babies, intrauterine growth retardations, neonatal sepsis, infant and maternal mortality. Oh. Yeah, I've seen. Most cases, anemia in pregnant women are a result of insufficient iron levels to meet the increased requirements of pregnancy and the key micronutrients required for hemoglobin. ladies and gentlemen, it is therefore prudent for all of us as health workers to measure hemoglobin to our mothers, and failure to conduct hemoglobin estimation leaves these mothers at a high risk of having the above already mentioned complications. Yeah, globally, 50% of pregnant women are estimated to have a decline in hemoglobin concentration normally during the first trimester. Could be because of hemodilution or increased demand, and mention it. And at Kawa Regional Referral Hospital, the hemoglobin testing of pregnant women attending first ANC was at 9, was as bad as that by January 2023, compared to the Ministry of Health guidelines, which is supposed to be at 100. This was attributed to a number of facts, but a few out of many who hanged long waiting time by mothers at laboratory, leading to runaways. We had one major laboratory, and it runs for the whole hospital. Also, mothers were not aware why we were sending them to do the HB testing. By that time, we had no current updated guidelines. The standard ones for essential maternal neonatal care. And so the health workers were not prioritizing the hemoglobin estimation to pregnant mothers. Moving forward, during Kigezi Regional Performance Review meeting, we had data, and it showed really low performance. So we conducted a work improvement team meeting and brainstormed some countermeasures. Yeah, we saw we really wanted, there was a need to have CME conducted. We had to think of printing out copies for current guidelines, and we hung them around for reference. We also looked around ourselves and improved on a way of communicating with these mothers with due respect, such that we could create demand. We also looked at creation and functionalization of our MCH laboratory, which was already there, but it was not functional. This, we looked at it could have helped us to have a one-stop shop center, and also reduce on waiting time, and make sure the clients go away with their results, because the previous experience was a bit. So the health workers also improved to prioritize on hemoglobin estimation. We had a peer who was only employed to retrieve files, but we looked at it if we could give an assigned duty to escort these mothers wherever we were taking them for the same test. And also we lobbied the HUMACHU estimations machine. Good enough, yesterday we looked at Vicent's tests. So if I go back to Kabale, the next consignment, I'll have to request for the Vicent's test because I did not know. So for some of you, if you don't have those HUMACHUs, you also request for them. So we are as bad as that by January. We took those countermeasures. So by December, by January this year, we were at 98. You realize that proportion of mothers receiving hemoglobin estimation during first ANC has gradually improved. They said we was bad as 3% by 2022, then to 100 by 2024. Ladies and gentlemen, it is important to explain to mothers what you are going to do, why you are doing it. Give them justification. You can also move an extra mile and tell them the next management when she's coming back for the second visit. This will help you to demand for the services. Then you also create, we put the unit, the laboratory in the same unit where you are carrying out your antenatal from.
You need to wind up.
Yes. This lessons learned is that whatever we are trying to do, we need to effectively communicate to our clients. We need to give them respect while you are explaining to this mother. Why? Because if you properly explain to her, on the next visit she will come back and say, last time you told me when I come back you will take me back for hemoglobin estimation after 36 weeks, and I'm also supposed to go, you also told me I'm supposed to go back for scanning to prepare for delivery. So if you have forgotten, she's going to remind you. Then you also need to, we also learned that creating a small, functionalizing that lab unit of ours helped us to bring back the results, put the results on the client's card, and reduced waiting time. We also found out that you're supposed to focus on using available resources and reorganize the processes of service provided for MCH. Recommendations is that we were told about the cancer of attitude, but let us change and have time and communicate to these mothers very well with their respect. We are also facing the end of year. Just look into that smaller unit of yours where you're operating from, create a smaller room and label that corner laboratory MCH, use what is there, and make your work plan properly. Then that will help you, one, to reduce waiting time. It will also help you to have that one-stop shop center, and it is also going to help you to organize your services as a key to efficient services in MCH. Over to you, Chair.
Thank you. Thank you, Imelda. Please take up your seat. Clap for Imelda again. I'll tell you why I want you to clap twice. This presentation from Kabale Regional Referral Hospital is a clear demonstration of use of QI, if you have internalized it very well. So thank you for applying QI to improve service delivery at Kabale Regional Referral Hospital. We are now going to hear from Acholi, Helen Nandudu from Acholi region. She's going to speak to us about how they are using or working with VHTs to improve case finding for children 2 to 19. Oh, those are not children, children and adolescents. Eh? Yes, using HIV self-testing kits. We want to hear from you, and the floor is yours. Strictly use 10 minutes. Thank you.
Yeah, thank you.
IT.
Helen Nandudu.
Meanwhile, you can introduce yourself. Thank you.
Helen Nandudu is my name. I work as the HIV prevention manager for Acholi. Yeah. I work as the HIV prevention manager for Acholi sub-region on the LPHS activity, Ankole and Acholi. I'll be sharing with us our learnings from implementing HIV activities and case finding for the young persons, and what we've been able to achieve through that approach. So, as Uganda, we strive to reach the first 95. We observe that epidemic control for finding children still remains a big challenge to most of us as implementing partners, but as a country. And we are aware that case finding is the first step to linkage of HIV care, most especially for children in terms of saving their lives, but also achieving the viral load suppression and having our children living a healthy life. So in the bid to address these challenges, as actually we piloted a strategy of finding children, the 2 to 19 years, in a space of about 2 months. For the first period, we did, the first phase we did 2 weeks, and then we're targeting 18 selected parishes or villages, and then we scaled it up over 12 weeks. In the map there, it's telling us about our recency data that we augmented in terms of trying to find where do we put our foot in terms of cases. So the green is basically those districts and parishes, villages that did not have a recent infection. So we focused on the red zones, and that's where we put our effort, as I'll be discussing. To do this work, we had 3 levels of interventions. We first looked at how are we going to enter or penetrate the community. So we looked at the VHTs as a way of our entry to the community, and also finding, and why did we look at this particular arm of community persons. We know that we have VHTs, yes, but we have different, and they address different health outcomes. But we wanted to leverage on their knowledge, and we specifically looked at the ICCM VHTs because they look at under 5s, and it was amazing when we looked at the registers. We noted that there were children that were frequenting the facilities and they were being referred for different illnesses. So we wanted to look at that. And then we sat and selected sites that would start this approach, and we reviewed their case finding data at facility to know, because as a region we had a target of 315 children to be found in that age band. So using our recency data, we generated the recency hotspots and also selected sub-counties with recent infections, as the previous map was showing. And then our selection was based on the recent a sub-county or village that had 5 to 10 recent infections or persons that were reported as recent. And then at household level, we looked at those sub-counties. We reviewed again further to select these villages with recent infections. We augmented the areas by majority of where the positives were coming from. And additionally, we worked with the health assistants to review the ICCM registers, as I'd alluded to it before. So we then identified 2 VHTs per village of the selected villages, and we trained them. One, we wanted to ensure that we align ourselves with the recommendations of Ministry of Health in terms of the 5 Cs, those principles of HIV counseling, testing, and then aligning them to the protocol, but also ensuring that they understand the screening tools. And also we generated a reporting template for the VHTs to ease their work. For each VHT, they were assigned a target. On a daily, they were doing 5 households, aware that a standard household in Uganda is about 4 people, 4 children, and adults, those are 6. So they would do the screening for 5 households a day, also adding up with their other roles that they do as VHTs. So with using the screening tool, they were able to, yes, they were able to understand that technique of screening, and then we introduced the HIV self-testing kit to them, and we oriented them on it, and specifically OraQuick. We did not go to the other blood-based kits. So all these clients that were screened and tested that found were eligible for testing, and those that were found positive were linked to care the same day. And from that activity, we noted that we had 100% linkage of all the 11, I've skipped something. Yeah, sorry, I'd skipped that slide. Yeah. So in total, we were able to reach 129 parishes, 260 villages, 130 VHTs were involved, and were able to test 1,005 persons at those villages. In this table, we show you that this was, we did not discriminate, though their purpose was to find the children, but whoever was found eligible in the household was offered an HIV test. And those that turned positive, of course, we transformed them to the national algorithm, and who were found positive and confirmed were linked to care. What was interesting is that of the total tests we did, we had 102 positives identified, and of those, 28% were children, 2 to 19, and 17 of these were children 2 to 9 years of age. The 10 to 19 were 11, and all of them were linked to care. Yes, you note that our yield was quite low in terms of the activity. But what was interesting is that those 28 children that we found, we disaggregated those children. We wanted to know what were the risk exposures for the children. Aware that we are already implementing index client testing, so we were wondering, where are these missing children? Where are they? So we noted that of the 28 children, 13...
You have 2 minutes, please.
Okay. A total of 8 children were confirmed from non-index household, and the 10 were from index household, and I will explain what a non-index household was. So in this, we tell you that the risk, we went ahead to, we developed a tool to assess the risk of these children, and we noted that 53% of the children were living with parents of unknown HIV status at the time that we reached the household, meaning that they were exposed, but the parents didn't know, and that meant that the approach is effective in reaching very many, you can score on all platforms. Then 4% were orphans whose caregivers did not know the status of their parents at the time they passed on. 1 was sexually exposed, was sexually active, but we did not find any cases of gender-based violence. So in the table there, it tells you our achievement. So we're able to, this approach was able to help us it actually contributed 9% to our total positive in a space of 12 weeks, knowing that every time they tested, a facility would not fail to identify a new case. However, we note that that approach is actually more beneficial to, it helps you to identify children of the age bracket 2 to 14, sorry. The above 15, we need to use a different approach, because you note that there was a 27% of that category. We learned that with this approach, you're able to link 100% of your clients that you find in care but also you're able to, you easily interrupt, or you're able to mitigate the interruption in treatment easily. And then in cases of, of new positives, attachment is easy for children, but index testing is done at once. And so we recommend that it's an approach that we can use, and the VHTs are a good resource to benchmark on. Thank you for listening.
A round of applause for Helen. Take up your seat. Thank you for utilizing the VHTs for quite a little more than they are expected, or what we know them for. That was very good, and for using recency data. So I think we wanted to, we could hold it here for now and have some questions come through from the audience, and then we shall take the next round of presenters. So I want to be seeing the presenters, so I might need to move. Yeah, so colleagues, we want to have a round of questions to our presenters here. I don't know where the microphones. Please don't give before I select. I need to be sure how many there are. Someone might grab it from you. Okay, so 1, 2, 3. Oh, these are quite many. 5. Oh my God. Okay, I am just giving 30 seconds for each, because we need to, you know, be conscious of time. So you can start from here and proceed like that.
Thank you very much, all presenters. My question or comment goes to Jude. Of all those interventions that you did test, what is attributable to what? In other words, what is the change that led to the most impact? Thank you.
That was quick. You used your time well.
Thank you, Chair. Still to Jude. I wanted to understand how did you, what was your measure of effectiveness of referral? And you know, yes, we saw referrals reducing, but what happened to the outcomes? What happened to the MDs? What happened to the perinatal death? Could we think that maybe referrals were suppressed and the outcomes could have worsened? Then the other thing is, okay, similar to what Juko raised, but the root cause analysis could have gone deeper, so that it well aligns with the interventions that you implemented. Thank you.
Thank you. Please tell us who you are. It is very
I'm Yasin Wamanya.
Okay.
And I'm an epidemiologist with Ministry of Health.
Okay, thank you.
Chair, I'm this side. My name is Dr. Jonathan Wangisi, Mbale District Local Government. Quick ones. To Brian Tasso Tororo, thank you for the presentation. We know that TB contact tracing is a routine that we are supposed to do. Maybe we are not doing it well. So I was wondering, what was the innovation? I've not, I think, picked. You made mention of aggressively addressing TB. Maybe perhaps you could unpackage the aggressiveness. We could find the innovation there. The other is to Irene. Thank you. As the local governments, we are grappling with the postpartum family planning uptake. You've shared good lessons, but I would love to know the investment you put in terms of training, SDS, supplies, because many times very many good interventions come, but they go with the IPs. You heard the minister lamenting about a center of excellence where he was looking under the table to look for in a QI. So we need to learn and see what is the cost. Can we do it minus you people? And then lastly, to Dr. Jude, Dr. Jude, as a partaker of your intervention, I want to thank you and your team that surely those interventions have helped reduce the maternal deaths and improve the functionality of the health center in our region. We say thank you and keep it up.
Thank you for appreciating. That's very good. Next.
Thank you, presenters. I'm Alexander Imbesiwe, and I come from Kabale. My question goes to Dr. Jude. First of all, I will thank you for the innovation you have done to reduce necessary referrals. Yeah, as you were talking, you gave an example of providing commodities to these point of care facilities so that they don't do refer. And one of the commodities you mentioned was blood. And as you know, that blood needs to be in safe place and stored well. And most of our facilities do not have these facilities. And that's the reason why they do always refer some of these methods. So as Mbali, as we have come here to learn, how did you do it so that these other regional fellows can learn from you and help these other facilities so that the referrals reduce as you have done in Mbali? Second question goes to Nanduto. Yeah, VHTs have done a lot, that is true. But when it comes to HIV care, some clients do not want to expose themselves to these VHTs. They still have stigma. So how have you done it? Since you mapped and you found the hotspots, to me, I feel that in these hotspots, you need to reach at least each household so that you are able to identify all. If you encountered those who did not want to have their confidentiality exposed, how did you do it so that you don't leave them out? Thank you.
You've exceeded the time. Next. Can we take only 3? Please, we need to be time conscious. We have another round of presenters and want to give them time.
Yes, I'm called Claire.
Yes.
Mine is to Irene. Thank you very much, the presenters. My concern, I would like to know the magic bullet that you're using to improve on postpartum family planning uptake within 24 hours. At least that one, I would like to know it so that I also take it home. Then to Helen, thank you very much about that innovation of using the VHTs. How do you deal with counseling, for example, the counseling before they do the test, then the consent, then again another one was about stigma. How do you deal with those 3? Thank you very much.
Perhaps the second last.
Thank you very much. I'm Innocent Arinitwe from Rushere Community Hospital in Chiruhura. My question also goes to Dr. Jude. I noted that in your presentation, you mentioned first accepting a referral at the regional referral hospital before the mother moves from the inner facility in the villages. How did you ensure that these vulnerable mothers are not left pending approval on a WhatsApp group before they can move for advanced health services? How did you make sure you minimize those issues of a mother waiting for 3 hours on a WhatsApp group to be approved to go to the regional referral? And the last one is to Miss Helen Nandudu. I noted one of your concerns was low yield, but I would like to tell you that 102 positives in 2 weeks, surely that may not be considered low yield. Well done, and thanks for utilizing the VHTs. Thank you.
Last.
Thank you, Chair. My name is Moses Balina from Maldima, Uganda, and my question goes to Dr. Mlowoza Jude. Thank you very much for the work. I was able to link your work with Professor Yanda's frugal innovations. But Doctor, I would like to get your thoughts about the 2 weeks attachment of the medical officers in the regional referral hospital. Is it that the district local governments within Mbale region are hiring medical officers who cannot perform a cesarean section, or this 2 weeks attachment is having other complex procedures, such that we can make a recommendation from this conference that the Ministry of Health should recruit medical officer special grade at a health center 4, because the Uganda Medical and Dental Professions Council will not be happy with the idea of having a medical officer perform a specialist procedure. Thank you very much.
Wow, it's a bit hard to juggle through those standards in a low-income country, but we'll get the response on that. I want to turn to the IT to flash the questions on chat on the chat. Forgive me, colleagues, we are caught up by time. So there's a question from, this has no person sending it. My question goes to Kabale Regional Referral Hospital presenter. Why did they prioritize HB estimates during first ANC visits, yet HB levels can drop at any point during gestation? Any other? Yes, to Irene, are there any specific best practices to improve community facility referrals for LAC family planning? Any other? Okay, so let's start from the far end, Helen, and we shall come like that up to the colleague from Tasso Tororo. Thank you. Please.
Yeah, thank you very much.
Be close to the mic a bit.
Yeah.
Thank you.
Thank you very much, Tim. And the first question was, how do you handle confidentiality with the VHTs? First is that when we approached the facilities, the selected facilities where we piloted, they were able to identify VHTs that they have worked with and were able to handle issues of confidentiality, but they were also acceptable to the community. And those are the VHTs that we worked with. And then, of course, I told you that we had to train them, orient them on the 5 principles of ensuring that there is counseling is handled well. And actually, most of our VHTs, the ICCM VHTs, have undergone a number of trainings. So you don't just underestimate them. We noted that they were quite good in terms of knowledge and were able to sail through with them. We didn't have any concerns about that, but also we kept a critical eye on an ear on the ground, working with the health assistant who supervises them. So we didn't actually register any resistance in terms of them reaching these households. First, they have been to these households, they were handling the other health components. So that helped us to sail through with it. And then what was even more exciting that I didn't talk about is that we continue to get calls that when our people coming back with HIV self-testing, we need to test. And you would find that in our community, everyone wants to line up. I need this service. That helped us quite a lot. Of course, for the persons that were identified positive, and remember it's at household level, there was ensured confidentiality in terms of course, the first thing was to talk to the health assistant, and we know that there is allowance for shared confidentiality, and that is one of the things that the the VHTs would do during the household education, and to ensure that the household understands that once we find that they are HIV positive, there is another layer of person that we are going to tell, such that there is a confirmatory test is done.
Thank you,
Thank you.
Helen. The rest you can reach out to Helen after here to share with you more insights on her work. Yes, Imelda. 30 seconds.
Yes, thank you so much for that very wonderful question. That why did we prioritize first antenatal? Basically, we are, from the bottom line, we are supposed to operate within the guidelines of essential maternal neonatal care, and we are supposed to do HB on the first ANC by any chance if this mother comes early, and also repeat it after 36 weeks. So that is the guide. And also when you look at the data, sincerely from 3 to 9%, there was cause for alarm. Thank you.
Thank you. Please.
Thank you so much. This is Irene, and I'll respond to the questions that were raised. One of them is the investment in terms of training. I would say that I'm glad to mention that we've entirely worked with the district to identify the district-owned family planning mentors. And our trainings take a form of facility-based trainings. So we do not pull away health workers from their duty stations. Again, in terms of commodities, we are working with these district-based medicine management supervisors to also address family planning commodities, as well as redistributions. These are all mechanisms that really can be done with limited additional resources. And our facilitation, since the activities are mainly district-based, they are around refreshment and transport refund based on the distances covered. The districts also do have support supervision activities and performance reviews where we really emphasize that postpartum family planning takes part on the agenda. Sharing our quarterly reports with the DHT, they are able to identify opportunities like outreaches, and they support all these interventions. So in terms of investment, really this is affordable. The other question was around improving postpartum family planning within the 48 hours. Our counseling and health education starts as early during antenatal. We also have, we leverage the district airtime to have radio talk shows on the importance of postpartum family planning. And our messages to the mothers, we talk about a return to sexual activity, we talk about their reproductive health intentions, and we also share with them the risk of having closely spaced births. So those ones really guide us that mothers make up the choices. And those that don't, we follow them after when they are referred back for immunization.
Thank you. Jude, you have quite many, but please try to be brief.
Thank you so much, Chair. Let me try to go through this quickly. First of all, someone asked about the issue of mothers wasting time during the WhatsApp consultation. Just for information, a quality referral should meet 3 criteria. First of all, there should be the right cadre should be able to should be available to assess the patient and give the first aid and ascertain the need for referral. The second attribute, there should be communication between the facilities to allow the receiving facility to prepare for this patient. And lastly, there should be a safe means of transport. So in form of communication, we are trying to ensure that the referral is necessary, and if it is to come, we are prepared to handle it better. And it's not just WhatsApp, but even the phone calls can be used. Then about the issue of delivering blood, we have a regional blood bank, and the director of the regional blood bank is part of the WhatsApp group, and he always responds, and actually responsible for dispatching this blood safely to the places that need the blood. And then about the attachment, we attach medical officers based on our referral data, and we don't have any special package we give to these MOs. We give a package based on the needs that we identify. So if the issue is about a particular skill, that's what we pass on. So it is tailored to the needs of the region. So we cannot recommend that you attach all MOs and give this particular skill. That should depend on your data. And lastly, about the effectiveness of the intervention, this is work in progress, and we are actually analyzing our referral data for the region to see whether there is an impact on the outcomes in terms of maternal and perinatal death, both in the region but also in the different facilities. And lastly, someone asked about what change is attributable to the interventions. Although I may not specifically answer this, but we have an idea of when we introduced which intervention. For example, the very first intervention we introduced was the attachment of medical officers. And then after 3 months, we introduced the second intervention of the performance review meetings. And then the last intervention was the follow-up visit that was introduced on top of the other two. And this is still ongoing, and of course, following what we get, we shall adjust accordingly. Thank you so much.
Thank you, Brian. I think you had one concern?
Yes. That question was, what is the innovation with TB contact tracing? Like I mentioned, it is routine to do TB contact tracing, but I want to emphasize the same words I used: being intentional, being aggressive, and having a team that is committed to doing this. And maybe to add that for what we did additional to this was to have the contacts traced within a week with a team of people who are knowledgeable on the TB symptoms. Thank you.
Thank you. Colleagues, allow me to request you to thank all our presenters for this round. They have been very interesting presentations. I'll request you to step down unless you want to take a photo with the chair, but the time is not there. So I request you to honorably step down and we go to the next round. So our next round, we have Sanyu, we have Rita, we have Henry, Edgar, and Jennifer. So we want to move to the next. So where is Sanyu? Thank you. I'm afraid I might be very strict on time. Please don't get annoyed. Yes, and feel free to share. So thank you. A round of applause for her. Thank you.
Good afternoon, members. Murajira Sanyu Noelin is my name. I come from Rengo District Local Government. I'm the main author. I'm glad to inform you that one of my co-authors is present, and allow me to show her to you. Joelia, please. Thank you. Yes, I'm here to share with you how we used quality improvement interventions to return at clients who miss appointments to care in less than 7 days of missing their appointments. Next slide, please. We all know that continuing on treatment on ART is a requirement for all people living with HIV in order to achieve a good health outcome and to avoid issues of drug resistance, high viremia, risk of transmission, development of opportunistic infections, and all this which can lead to poor treatment outcome. So, at Chiwangala Health Center, during one of our facility data use meetings, so we realized that only 43% of clients 20 years and above who had missed their appointments returned to care within a week, compared to the MOH standard or guidelines. So we felt we need to get serious on this, and we had to do something. We began a HUI project. I did the root cause analysis, and through brainstorming sessions, we came up with issues like stigma, non-disclosure, forgetting return dates, relocations of clients looking for jobs and marriage. All of these were the root causes. Next slide. So, what did we do to address those root causes as Chwanga Health Center 4? We came up with strategies. The study period was from February to January. One may wonder why we are presenting up to January. By the time we submitted the abstract, we had started the project about 5 months, and we were not there. We had not hit the target, so we continued. Next slide, please. These are the strategies we came up with. One, we intensified updating clients' biodata at every visit to be in a know of where our clients are. We attached at clients who miss appointment to community peers and existing CBOs for follow-up. Home at delivery was done by community peers to those clients who requested for it. We intensified that because they had issues of transport. Others were busy. As they become stable, they become busy looking for money to cater for their families. Line listed clients who missed appointments and reached them immediately through phone calls. That very day after clinic, we line list those who have missed. We place calls, phone calls, and put, with a red pen, put a yes. We correct those whose phones have gone through. And for those whose phones could not go through, we could then again attach them to community peers for follow-up, for home visiting. We enrolled more clients on CDDP, CCLADS, and again realigned dispensary art to match with the scheduled appointments. Next slide. What did we achieve? Progressively, we registered some improvements, and majorly, much work was done by community peers, to be sincere, because they could follow up clients and give a report for at least from March to around August. We registered improvements, and unfortunately around September and October, during the transitioning of the IPs from RMNCAH Health Sciences program to IDI, there our community peers were put on hold and stopped working for that period. Basically, the performance relied on facility interventions. Next slide. I've explained that. Next slide. What did we learn? We learned that timely follow-up of clients who have missed appointments contributes to continuity art, and it may help us get a significant viral suppression. Routine update of locator forms eases follow-ups and enable us to access clients through home visits. Dispensing multi-month drug refills also reduces clients. Yeah, it helps them to it gives them time to look for money, again to come back. Attaching new art clients to community peers, it also helps. They feel they are fully responsible for those clients. In case they miss, that peer who was assigned to such a client will be responsible to bring that client back. Next slide, please. What do we recommend? Community peers assigned to different arts clients should come from the same locality as their clients, because it's easy for a peer from village A to look for clients from the same village. Peers should take on a father-mother role to add clients and assume full responsibility to those clients assigned to them. So, and give accountability, they will be able to give accountability for those clients every month. How many they have returned to care. Clients who have missed their appointments and have bill balances should also always be rescheduled. They need to carry out timely pre-calling, pre-call reminders using phones. Next slide, please. Acknowledge. Yes, I acknowledge the Minister of Health for setting up standards that guide the implementation process. I also thank my implementing partner, that is IDI, my district, the DHT members for the capacity building, and the funding agencies, CDC, PEPFAR. Thanks you for the financial support. Be blessed.
Thank you. Please come over here. Thank you for sharing with us your innovations to improve 7-day follow-up for HIV clients. Colleagues, we want to move to the next presenter, and that is Rita Namusisi. So Rita is going to speak to us about expanding access and acceptability of DMPA SC. Oh my God, what is that? Self-injection services through the village health teams in Uganda. So, and this was some work done in Kampala, capital city. So, the floor is yours. Thank you.
Thank you very much, our moderator. I'm not Rita Namsi, I'm Nakazi Gracie Lubega, and I'm just presenting on behalf of Rita. Our study was about expanding access and accessibility of DMPA-SC self-injection services through the VHTs in Kampala. I did this with my co-authors, that is Rita, Justine Namakula, Alex Nakanwaje, and Becca Lukwago. Next slide. Yes, DMPA-SC is a common contraceptive method that almost accounts to 30%. It's one of the injectables that is widely used by women of reproductive age. And according to some evidence, women, especially those in Kampala, prefer bringing services closer to them than you referring them to the health facilities. So we saw that extending that already VHTs were doing this. They were providing short-term methods, including injectables. However, they were providing DMPA-SC, commonly known as cyanopress, to provide administered. That is, they would inject the clients. And yet we wanted to see that women's autonomy, confidence in accessing and utilizing family planning. So it was critical to empower these women at their places of convenience using the same VHTs. Next slide. I don't know what happened. I think the slides yes, I can go on as he sorts it out. What did we do? So what we did, we went to the DMOs, those are the division medical officers, through the recommendation from the director of health services, and then we had to pick out areas in the 5 divisions that had the need that had a high burden of FP. So we worked with them through the project of Discover Your Power, of delivering innovation in self-care, commonly known as DISC. So we are able to identify 78 VHTs. We trained them using a specific selection criteria. The training was really intense. We had the practicums at the different health facilities, and we tried to address fears, key messages that would really enable these women to learn to self-inject. On top of that, we continued to do, we had our mode of payment, which through the incentive scheme, but also continued to do the support supervision to these groups. We also linked them to health facilities where they would continue picking the products, but also linking VHTs for linking clients for services. Next slide. This is what happened in Lubaga. We did, those are the high volume and high need parishes. We went to Ndeba, went to Natete, and then we linked 15 VHTs to those particular facilities. In Kawempe, you know Bwaise, you know Wandegea, you know Makelere, really full of women of reproductive age. So we linked 20 and VHTs, and those were the linkage facilities, both private and public. We went to Nakawa, we did the same, and the linkage facility was Kiswa. We went to Central. Central was a bit hard. As you can see, there is Kololo, there is Kamocha, there is Kisenyi, but we were able to link them to Kisenyi Health Center 4, and we did the same to Makindye. So with these trainings, we were able to partner with USAID MCH, and this helped us to cost share. They had their peer mothers who also helped us to have a bigger mapped area. The VHTs were linked for facilities, were linked to facilities for commodities, referrals, for LACs, and also reporting. We didn't do this alone as PSI, but we worked with the facility focal persons because we wanted them to own up this even after we had left, and also to ensure that they provided stock, they restocked for the VHTs, provided timely reporting, ensuring one of the issues with VHTs is always reporting. So we made sure that we mentor and monitor them, but also waste management, given the fact that this had injections involved. Next slide. So as a result, this is what we're able to see. The SI uptake and proportion, and proportion was like as shown there. In November, that's when we started. We saw that we had over 5,000 women self-inject at community level, contributing around 81% of the total visits. And then between November and December, we saw that whatever you're seeing there was just for one division because the rest hadn't started. And then between January and Feb, we see that we have a curve going up, and that was attributed because of stock. We had done the training, but stock for Sayana Press was not available. But from March, through lots of things, interstock transfers, VHTs getting also more confident to train women, support supervision, and then reporting at all divisions led to that upward trend that we see. Next slide, please. So according to the 5 divisions, we see that there was really a significant proportion of SI, that is self-injection, to PA, and we see that Kawempe was really doing so well together with Lubaga because of those different reasons that you can see there. And next slide, please. We also saw in general that VHTs contributed over 60% of DMP SC volumes reported at the different facilities. Those are the different facilities that we are working with, and the curve really went up as we continued working through the 3 quarters. Next slide, please. Some of the lessons learned: stock availability of all short-term methods really affect performance. Then group mentorship provides peer-to-peer mentorship. group SSVs after training. You don't just leave the VHTs. You have to continue doing SSVs for them to share their challenges, experiences, so that we get solutions together. Then working with the health technical leadership also leads to sustainability, because we didn't do it as PSI. The divisions know what we did, and even after we phased out, we still get reports. Then trainings, if you're to train VHTs, it has to be as local as possible, use the local language, like come down to that level, they'll be able to get it. Our recommendation is capacity building, value preposition. That is very important, because the VHTs will always ask mfunira more. So you have to bring that value preposition in whatever you do if you're to work with them. Utilize the FP for co-persons, then have a clear referral tracking system, including calling back some of the clients to really verify if they got the services, and then give them reporting tools, but take them through. My conclusion, dear Chair, is we can expand SI training through the VHTs as an effective approach, ensuring that we have high uptake and localize our support for predicted long-term benefits. This will help us to reduce our facility work overload. Thank you very much.
Okay, thank you. I forget your name. Grace. Okay, thank you, Grace. Let's move on. So we are going to receive another presentation from Henry. Henry, are you around? Or a representative? Oh, that should be a representative. Okay, so we are going to receive a presentation on sustaining 5S, quality improvement approaches, from Kabale Regional Referral Hospital. I know Kabale was at one time a model facility for implementing 5S and TQM Kaizen, something like that. So we want to hear how you have been able to sustain that. Thank you.
Thank you. Good afternoon, everyone. Good afternoon. So I'm Judith Tumusime. I'm from Kabale Regional Referral Hospital. I'm the QI focal person. As they organized the presentation, I want to thank my co-authors. That is Matende Henry, then Didas Rutunje is there, the regional QI focal person, and our director, Dr. Nyeko Filbert. Next, the theme is sustaining quality improvement system and approaches for 5S, a case for Kabale Regional Referral Hospital. Go on. That is the area photo for Kabale Regional Referral Hospital, which oversees Kigezi sub-region, where there is Kabale, Kisoro, Rukunjiri, Kanungu, Rubanda, and Ruchiga. Yes, we go on. The introduction, Kabale Regional Referral Hospital implements 5S, quality improvement systems and approaches as a standard. Sustaining these systems and approaches requires team dedication and buy-in with minimal input from external stakeholders. So Kabale Regional Referral Hospital 5SCQI was directly supported by, that is our introduction, by JICA staff who was a volunteer by then, around 2014-15, and exhibited an overall performance of first out of 11 regional referral hospitals that were assessed by then, and so it came out as #1. But later on, it dropped and became the 9th out of 11 in 2017, with that performance of 44%. So following an initial decline in QI implementation in 2017, there were those capacity gaps, both technical and non-technical, These were attributed to poor attitude towards 5S and QI, less involvement of the hospital leadership, and 5S QI knowledge gaps. No focal person was there by then, no rewards or recognitions, no facilitation or any budget for 5S and QI. So the methods, the hospital leadership identified and trained a substantive 5S focal person to mentor technical and non-technical staff. So they gazetted also a 5S QI office. That is one of the photos for the QI office that we attained last year, 223. You can see it is signed by our director, Dr. Nyekov J. Filbert, and that is one of the motivation. There was also introduction of competition and awards of the best performing units, and that is actually one of the awards. That recognition is so important. Then routine departmental or unit performance assessments. That photo, one of the mentors is doing an assessment, and they are on the notice board. So the mentee is being guided on the right thing, on doing the right thing when it comes to working on the notice board. Next. Monthly QI meetings for feedback and action planning were regulated. That is one of the QI meetings there. Conducted new staff orientations, refresher trainings, mentorships, routine engagements of staff during 5S activities. That is more involvement during sorting and setting. That is where you need to start from. That is one of the photos where staff are involved in zoning. They are doing zoning on the floor. There was also routine technical support supervision by MOH, SCAP department, plus the JICA team, and areas of improvement are identified, and then we look for solutions. In that photo, you can see, if you're observant, there is Dr. Agre there, Bateisaki, there is the JICA team. They are all there along with the staff for Kaba Regional Referral Hospital. So we also developed QI projects to track 5S implementation and waste management. The hospital dedicated a support budget for 5S QI. Go on. The results or discussion, that is the performance according to the years up to 222. We go on. That is the results of assessment 222 to 23. You can see Kabale is still leading. It is there on the extreme end. Then the overall monthly 5S performance for the 35 units in the hospital. So we do monthly assessment of 5S, and we usually display these results. We share with the units, and this is the average of all the 35 units. It is monthly. We do it every month and give feedback. Go on. That is the first award in 5S received by Kaba Regional Referral Hospital. That was in 2014. And there is, next is an award received the last QI conference in 2022. And we appreciate that. This is, we've put a few photos about the journey of how we were 2012, 13. You can see the medical record is improved very well. 2012 to 13, Then 18, it was looking like that, and 19, and to date, you can see where we are. And medical records has received an award there. You can see it because they have been performing well. Go on. This is the journey with the hospital compound from still 12, 13, 14, and how we have progressed because of 5S. In conclusion, to sustain 5S QI systems and approaches, it requires dedicated hospital leadership, team commitment, and facilitation for 5S tools.
Thank you. Thank you, Judith.
Okay.
I'm going to ask you to clap 3 times. First for Judith. She has been a confident presenter. You can take your seat. The second is to cover a regional referral hospital team. And the third is to the leadership of the regional referral hospital of Kabale, specifically for allocating money for 5S. That is very good. I don't know whether Dr. Philbert is in, but we would like to hear more about that. Thank you. He's in, eh? Okay, thank you. That's very good. Let's go to Edgar. Edgar is going to speak to us about strengthening client literacy and provide us skills to optimize maternal retesting at PNFPs. I don't know where. He will tell us. Over to you.
Yeah, thank you very much. Good afternoon, colleagues. I am called Edgar Tusubira. I work with the Uganda Protestant Medical Bureau, and we support private not-for-profit health facilities across the country to offer comprehensive HIV/AIDS services. This presentation is focusing on how we've strengthened client literacy and provide us skills to be able to optimize maternal retesting at private not-for-profit health facilities in 8 USAID supported regions, as you're going to see here. So just a background and a program that is the problem that is being addressed. Uganda, as we are all aware, has made significant progress towards eliminating mother-to-child transmission of HIV, that is EMTCT. And the national PMTCT impact evaluation that was done between 2017 to 2019 indicated an overall mother-to-child transmission rate of 2.7% at the end of 18 months. So this rate was highest among mothers that are not on lifelong ART, compared to 1.2% among mothers on ART, and 9.6% among mothers who are virally non-suppressed. That's still according to the national PMTCT evaluation survey that was conducted between 2017 and 2019. So we know very well that the HIV seroconversion during pregnancy, labor and delivery, as well as during the breastfeeding period, poses a very great risk of transmission to the baby due to the associated high maternal viral load that usually happens within that period. So the Ministry of Health recommends scheduled retesting of pregnant and breastfeeding mothers to be able to aid early identification, but as well as early ART initiation of women who contract HIV during late pregnancy, labor and delivery, as well as during the breastfeeding period, to be able to mitigate transmission to their babies. So the USAID Local Service Delivery for HIV/AIDS activity, LSDA, that is being implemented by the Uganda Protestant Medical Bureau, is supporting 188 private not-for-profit health facilities across the country in 57 districts to be able to optimize maternal retesting and accelerate elimination of mother-to-child transmission of HIV. Our project design, we implemented this between January 2023 and this data runs up to September 2023. But again, even if you are to show a picture of up to January 2024, you'll see market improvement according to the methods that we used. So we supported the implementation of maternal retesting improvement change package, and this is a complete package that we put together to ensure that we improve maternal testing across the different facilities. In this, we provided peer literacy materials to mentor mothers, and these were translated in the local language to improve health education at triage to create demand for retesting. So we picked out the materials that you already have and put them in each of the local languages at each of the regions that we support. And these were in form of local manilas and the marker, and the midwife translates them in the local language. We also, because you know that PNFPs have high attrition rates, so we purposed to do continuous reorientation of midwives on maternal retesting guidelines, distributed job aids as well as standard operating procedures, but also, most importantly, innovated the use of a maternal retesting tracker to be able to aid the quick identification of the mothers that have come for another visit and they're eligible for retesting at the different MCH points. Then lastly, we continuously displayed PMTCT codes at the different service points to enhance proper documentation and supported PNFPs. You know that even if we had done all this, if documentation is not done very well, again, we will not meet our goal. So maybe just to show us, the lower part is showing the innovation that we made of the maternal retesting tracker. And we formed this according to the scheduled retesting as per Ministry of Health guidelines. So we made a tracker for ANC, where we know that we're supposed to do the retesting in the 3rd trimester, or as and when the mother gets an HIV or becomes substantial at HIV risk. And then for the postnatal period, the tracker again follows the immunization schedule, and again at 15 months. So the upper pit is just showing part of the literacy material for a patient, and it is in pictorial form, and these were printed and put at the different points within the health facilities. This slide just shows us what we were able to achieve, and we looked at the different quarters. We looked from the quarter of quarter 1 financial year 2023 up to quarter 1 of financial year 2024. And we see that across the different quarters, there is a marked improvement in the maternal retesting trends. Most importantly, we see that overall we came from 47%, we went to 66%, up to that period when we were at 94%. And I can tell you that data that we had up to January 2024, we were actually approaching the 100% mark, which we think that this is a very good change package. Our recommendations and implications for Uganda: HIV seroconversion during late pregnancy or breastfeeding is a key driver to vertical transmission of HIV, but also provider skill gaps and low maternal literacy are a major barrier to the uptake of maternal retesting at PNFP sites. The provision and utilization of appropriate job aids and simple literacy materials, especially for the peers, effectively bridge this gap. Peer mothers are effective messengers in delivering health education to pregnant and breastfeeding women. I just want to mention that when we were first piloting, the first month when we were piloting this innovation, we started with facilities that were offering group antenatal. So we utilized a lot in the first and second month, the group antenatal pairs.
1 minute.
So the proper documentation and using the right PMTCT codes and regular data views drive improvement in uptake of maternal retesting. We acknowledge the following partners, of course, MOH, USAID, UHA, the SBCA partner. We worked with them to develop some of these materials, but also the other local partners, the LPHS partners that we work with in all the regions that we support, as well as the district teams that are always very crucial in development of these packages. Thank you, team.
Thank you, Edgar. Take up your floor. Please, a round of applause for Edgar. Jennifer, Dr. Jennifer Dong, please take up the floor. So Jennifer is going to speak to us about boosting immunization rates through strategic interventions. Some work done in Agago. The floor is yours. Thank you.
Thank you very much. And good afternoon, ladies and gentlemen. Good afternoon. I know I'm standing in between lunch and the presentation, but I'm going to make it brief and to the point. So I'm going to present boosting immunization rates through strategic interventions and experience from Agago district, but one experience that we have extended already to the rest of the region, and we're seeing results. Next slide. So just to give you a brief about Agago district, it's in the eastern part of Acholi. Its current total population, according to UBOS, is 266,000. But what is important to note is that the estimated children under 1 year who should benefit from immunization services is 2,823, who will benefit from about 14 to 15 facilities that offer immunization service across that vast land you're seeing there. And what is unique about it is that it's bordering the cattle rustlers, so they are literally affected by cattle rustling as well. So the situation at the beginning, that was December particularly, we realized that there were high dropout rates in the region, in Agago particularly, but also across the region. And also that there is low coverage for fully immunized. In as much as MR1 was high, the coverage for fully immunized was low. So the biggest challenge was the issue of micro-planning, which was poorly done across the district, literally because the capacity of the EPI managers were not built in EPI. Persons are identified and attached, but they don't know what they're going to do. They learn on job. And then the issues related to poor documentation and underreporting, and issues related to inadequate data use during performance reviews and quantification of vaccines. So what did we do? We started off with stakeholders engagement to bring them on board to understand what EPI services are. And this cut across the technical and non-technical wing. We looked at the health workers, we looked at the DHO's office, the DCCT, and also the RDCs and the LC5 to onboard them. So with them, we shared the root cause analysis that we had conducted at district level and the data quality assessment and the gaps in maintenance of especially cold chain for vaccines from the store at the district, but also from facilities to points where they are giving the services. So in that same engagement, we shared talking points, especially to the non-technical wing, who would hardly talk about immunization services when they have gatherings. We also looked at data, the availability of the tools, capacity building in terms of documentation, but also reporting, and we supported data cleaning on a monthly basis to ensure that what enters DHIS2 is what is representative of the performance of each facility. The mainstay, the community, we had to engage with them through community dialogues, through sensitization, but also improve facility-based health education. And then with support from the RDC's airtime, we were able to conduct radio talk shows in the various radio stations. Then at facility level, we had to build capacity for the healthcare providers who are managing EPI, but also help them do data review on a regular basis. And then we trained them on how to, especially microplan. They didn't know the document called a microplan. I don't know how many health workers know. So for local ownership, we had to onboard local leaders at sub-county level as we would go out to conduct outreaches on selected sites. And the religious leaders and other school leaders, especially the teachers, who were amazed when one of the teachers told us that you tell us, we change the household, because one teacher will tell 50 pupils, and those 50 pupils will go to 50 households. So that ripple effect, we saw it come through. We also urge them to integrate EPI services in all activities. So when you're going out for family planning, you have to carry the cold box because the mother will come with a baby. Then we developed a virtual platform for management of vaccines, but also now literally performance management because we share data through it. But the most important is engaging the VHTs for purposes of community mobilization and continuity. So the results that we saw is that there was a marked improvement, first of all in DPT1, which is a measure for the first measure for zero-dose children, but also across all the other antigens. So we see that we moved from 96%, DPT1 coverage was okay, but the dropout rates were really high. So the other antigens, we had to move from around 80% to as far as 100% in most of the sub-counties. And then we also see a drop in the dropout rates. So we started from as high as 8, 9, 10%, actually 14%. And then some sub-counties selected had up to 30% dropout rates. And we went to down, now we are at 5, 3%, negative 2%. And that is what we achieved through this information. Next slide. So when we see the ripple effect at regional level, still giving just a summary of what was done, we see that there's an improvement in most of the, actually in the January data, all the districts are in category 1 and 2, with the exception of Noya, which is still in category 3. So Agago, Lamour, and Pade are in category 1 currently, and then the rest are in category 2. So that means we've improved access to care. Now we need to complete the cascade with utilization. Next slide. Again, when you look at the zero dose across, this was comparing 2 quarters. You see a marked improvement in a marked reduction in the number of zero dose children across the region, particularly if you see Agago. We also see it remaining in green. We see the Lamour and Kitgum also moving to green. And then when you see the trends down there in the graph, we see a nice drop across the region. But the marked drop was in the month of Integrated Child Health Days, and all of us understand why. Next slide. So particularly, what do we learn from here? That delineating and roles and responsibilities of the different stakeholders matter a lot. Literally, the DHTs were in a mix. They didn't, like, a blame game came up. Who should do what? They are responsible for capacity building of all the health workers. They're supposed to monitor, support supervision, and ensure everything is being done right. The gatekeepers, they didn't know what to do. So we had to sensitize them to let them know that they are the ones to let the community know what is available in the facility, but also do the referrals to the facility. The local leaders, they are responsible for social mobilization, but also our IPs. The various IPs had to come together to put their hands together to do technical assistance, data analysis and sharing, but also making sure that commodities are available. Next slide. And then the second thing is that we need to regularize performance reviews for EPI services. Most of the time we do performance reviews and we do HIV, we do a bit of RMNCAH, and we forget about EPI. It's one of the things that we need to take up and start doing. But the game changer is involved in the community. If we don't bridge the gap in the community, we don't address the fears, the myths and misconceptions, and if we don't take the services closer to them, we will not achieve what we want to achieve, especially for some indicators that are strictly directed to more of a community uptake. A child is not sick, but they need to be immunized. And then we need to close the gap between the service provider and the recipient of care. This, I talk about customer care. When I come to the facility, what package do you give me? Does it attract me back, or does it send me away for good? So those are the things we need to focus on. Next slide. So we learned that, just like I've said, the community is a game changer. All the myths, the misconceptions, the hesitancy, distance, poverty, the driving factors to low uptake of all medical services, but particularly vaccines, are in the community. So we need to work with them, sensitize them, give them the benefits so they can choose the right thing. The second thing is that our health workers need to understand EPI. Some of us even don't know the routine immunization schedule now. We don't know how many diseases we benefit from vaccine prevention. So we need to build the capacity. They need to know how to microplan. They need to know which vaccine comes when, what are the side effects, how can we handle it when a mother asks, and all that. And then also the use of the virtual platform is helpful. It helps. We share a lot of information there, including data. I thank you so much for listening.
Thank you, Jennifer. Take up the floor. And thank you to the audience for being patient. I want to assure you that within the next 10 minutes we shall be out of here. So it is time now to get some questions from the audience. Microphone. However, I would like you to allow the chair ask first. The other time I forfeited my questions because of time. I just have only two. One is to the colleague from Ruengo, and it's good that I'm speaking to a health worker direct from a facility. I wanted to request you to share your experience with phone calls within 7 days after missing an appointment, because before all the other interventions are done, we should have failed on phone calls. I want to ask, what is your experience? How many people, or what is the rate of patients that return on phone call? Because delivering medicines and other interventions you shared are good, but they have other strings attached. You must be able to meet some cost there. Two, to Edgar, you seem to have, I think, gotten the master key to improving maternal testing. This is an area that is disturbing most of the regions. You spoke about a number of interventions. You talked about job aids, the codes, and so on. And lastly, you spoke about the tracker. Of course, I would like to know, how do you do this tracker? Is it tracked at IP level or at facility level? Do facility staff know that I have this mother who is due for retesting this time? So I want to know there. And also, on all these interventions, are you able to say that use of this tracker was the biggest contributor to the successes that you got? How do you rate it with all the other interventions? Thank you. So with that, I want to move to the next, Dr. Nkoyoyo.
Yes, thank you, Chair. I have just two people to ask. One is Noreen. Noreen is from Rengo. Noreen, unfortunately, you are a health worker. I would have asked better if you weren't one, but let me ask you all the same. There is a tendency of health workers conniving with the peers to indicate that they have been able to identify a person who did not attend a clinic within a few days for purposes of benefiting from the facilitation. Now, and it has happened very many times. You send the list, these are the people we have identified. We went for the community for back to care. And then they indicate that people came the following day for their drugs or the following week. And yet they had come even anyway, earlier. So how did you prevent this from happening at your facility? Now, the other question is, do you have any, because it was out of the scope of your work, but I wanted to have an experience from you. Do you have any strategies that can help us prevent treatment interruption, apart from multi-drug dispensation and the facility? Do you have anything that you think has worked? Then the other question is to my colleague Edgar. It is close to what the chairperson has asked. Edgar, what is the difference between this tracker and the audit tool? Because this audit tool can identify mothers who are due for retesting, and they can identify them to the smallest unit of identification. I don't know. So what is the difference, so that we know how we can either drop the other one or merge the two? The last one to you, Edgar. Given that these tools were identified, were developed, designed and developed by you in support of SBCA mechanism, the literacy tools, are these tools available to the other people, to the rest of us, or they were designed for you and they are only applicable in your health facilities? Can we access them, the rest of us?
Thank you, Dr. Nkoyoyo. You've asked many questions. I want to request the rest to be conscious of time. 30 seconds.
Thank you, presenters. Yasin Wamanya, epidemiologist, Minister of Health. I have particular interest in immunization, and my questions are going to the presenter from Agago. Sorry, I missed her name.
Jennifer.
Jennifer, yes. I wanted to know, I looked at the baseline assessment for the different antigens. How was MR2 performing? It conspicuously missed out. And you know, this is currently the biggest challenge. When we are measuring herd immunity against measles, actually we are looking at MR2 coverage. That's the standard if we want to know where we are standing. And then what was your measure of assessing someone as fully immunized? Because this one has also since changed. Since we have second year of life vaccines, I would only think someone is fully immunized when they have received the second dose of measles rubella. So what did you use to measure to get the 81%? Because this would be very, very impressive. Then you also seem not to clearly specify your objectives from the beginning. We only see that at results level you are talking about dropout rates. The access seemed not to have issues because DPT1 was okay. So you need to specify the objective so that you guide your root cause analysis properly. And lastly, when I look at your results, let me hope this is a project that is still ongoing. I would say it is yet to work, especially when you look at the dropout rates. They are still fluctuating and generally out of range. It's not only about reduction, but we want to be in the range, 0 to 10%. So if you have a negative dropout rate, you are still not doing well. Thank you.
Okay. Next. Why are hands on one side?
Thank you, Chair.
Proceed.
Yes, my question goes to Noeline. I'm Irene Mildred Neumbe. I work with USID LPHS Karamoja. We note that at baseline, you were at 43%, bringing back to care within 7 days. Perhaps if you could attach a denominator, I'm just trying to imagine the magnitude of the problem we are speaking about here. Secondly, if we were tracking bringing back to care within 7 days, but your run chart was monitored on a monthly basis, how effective was it monitoring that project on a monthly basis? Thank you.
All right. Colleagues with microphones, you need to also come this side.
Okay. Thank you.
Thank you very much.
Who is that? You seem to have hijacked the microphone. Okay, proceed. Proceed.
Okay, thank you very much. My name is Peter Okello. I work with Lira Regional Referral Hospital. First question and concern to Kabale. There was the issue of allocation of a budget 5S. We all know how our regional referral hospital budgets are structured. I'm wondering how this is specific, that there is a specific budget for 5S activities, if it is not affirmative action that just responds to the budget for 5S. unless this recommendation could come that we have a specific program, like we have, say, climate change or mainstreaming of 5S activities. The second question goes to Jennifer. I think in the first case, the district capacity needs to be built, because I'm seeing the doctor kind of taking it all. But I would imagine at this point would be comfortable having a person from the district being the one presenting and capacity being built for sustainability. Also, in the recommendations, she is putting it that in the performance review should be held focusing on EPI. But I think we need to recommend an integrated approach, such that when performance review is being done, you are looking at, say, EPI, medical equipment maintenance, data, and others, such that people present and is shared. Thank you very much.
Thank you. I request colleagues you be precise with the question. Let's take two more, one here and the last side of the room.
Thank you very much. I'm Ruth Timbgamba from Rukunyu Hospital. Mine is to Noelin. I request to know how you managed to handle those clients that missed the appointment, had no phone contacts, and they were from different places and very far, where you could not do the home visits. And also, I wish to know, how did you manage to visit all those clients as far as funds are concerned? Then another is to Judith. I'm requesting to know how you have been doing the 5S assessment at your hospital. And if there is an assessment tool available, please, I request you can share with us. And also, I need to know how often have you been doing the assessment. Thank you.
Next.
Thank you very much.
10 seconds.
Yes, Dr. Lemkol, DHO Moroto. Mine is to Rita. Urban populations tend to have a very low opinion and less acceptability of services from the village health teams. So I'm really wondering how you were able to overcome this and be able to mobilize over 5,000 women to self-inject. The other one is, how are you also able to address issues of injection safety among the users? And the other one is, how were you able to replenish stocks of cyanopress, because we have had challenges in most of the regions where this was rolled out, and in fact, it has stalled over time. Thank you.
Thank you. Last. That should be the last. No. We are taking the colleague from, I think, IRC. The rest you've emerged later, so our apologies.
Thank you very much. I'm called Francis Tomoyo. I work with IRC, Yumbe. My question actually goes to the person who was presenting about the self-injection family planning method. I want just to know if at all maybe the project we were doing, it was only to scale up the uptake of the method, or maybe she was also looking at other indicators, because as we know very well, much as we want to scale up family planning, we know that we need a productive population in the next year to come. So how do you really measure that these people that you send the VHTs to them actually did the family planning method and then were satisfied? Was there any mechanism for feedback, or were they coming back for the second doses or the other? Then how was she able to maneuver with the male involvement in that? Because we understand in low health facilities, communities still have a lot of myth concerning those. Thank you.
Thank you. So that marks the end of our questions to the presenters. This time round, I want to start from this side. So, Edgar, you go first. Thank you.
Yeah, thank you very much. Thank you very much. I had 3 questions, and they were relating to the utilization of the maternal retesting tracker, but also its utilization. The first question was who uses the tracker? This is not an IP tracker. This is actually a facility-based tracker that is utilized by the health workers, and in this case, the midwives. Now what happens is that a midwife is able to use that tracker to be able to line list mothers that are due for a retest but previously tested negative in the previous ANC visit. Now that takes me back to the second question that Dr. Nkoyo asked, that we already have the audit tool and then we have this tracker. I just want to make for clarity that the PMTC audit tool that we have is for HIV positive mothers. And this tracker is tracking mothers that previously tested negative, and we want to contribute to stopping mother-to-child transmission. So we are using this tracker to track the HIV negative mothers and retesting them at the different schedules as it is. So I think that clarifies. The last question was about the involvement of one of the USAID funded partners, that is the SBCA. Time and time again we work with SBCA to support mobilization of clients, but also develop sample tools for client literacy at facility level. And these tools sometimes may not be scaled up because we want to have this kind of feel, whether it makes sense to the rest of us, and then these are adopted. What I can say is that this tool is available for use for all of us, and that's why we have these conferences. Thank you.
Thank you. So, Noeline, is it
Yes.
Noeline? Yes.
Thank you. Thank you. Thank you, everyone. I have quite a number of questions, but I will try to be brief to answer them. First question was about the experience with the phone calls within 7 days. Phone calls that method doesn't work alone. It works along with other interventions. We said we have pre-call reminders. For phone calls which don't go through, we encourage peers, community peers, to do a home visit. And again, we have CBOs in our area. They are funded to carry out this work. So we again attach those clients to the CBOs available within their locations. Next question about the strategies, that how do we convince, the problem of peers conniving with health workers to rename clients that have missed such that they can get money. It hasn't been the case at our facility, but still I will say the supervision, the internal supervision within the facility cannot allow that, because the facility managers work hand in hand with the in charge, and that cannot happen. The strategies to prevent drug interactions, first of all, we encourage detailed literacy, giving of detailed information while initiating clients on art. When you tell them the benefits of art, when you give them the relevance of continuity on care as they are initiating treatment, they will keep on demanding for more for treatment. They will not take it for granted. Again, updating of biodata. Their biodata helps us. The locator forms are updated now and then at each visit to ensure they don't get lost. Those are the interventions. Then I'm sorry, I didn't put the denominator and numerator on my graph. I missed that. About how effectively do we monitor the indicator monthly. Of course, we use the missed appointment register. There is a column of when the patient got lost and when that client returned. So we determine whether this patient came within 7 days or later. Another question is about how we handle the phone calls for clients who come from far. And again, still I will attach this to CBOs we have. They are funded, they have money to look for those clients, and we encourage clients to get treatment from nearby health centers. We have quite a number of health centers that provide art services in Irengo.
Okay.
Thank you.
Yes, thank you very much, moderator. Thank you very much for the questions. There were not so many. I'll start by acknowledging my colleague, Doreen Muyama. She's in charge of quality improvement and control at PSI. So as I do most of the running around with behavior change, she ensures that we have quality at the organization. The first question was about the population. Yes, these are really two different settings, the urban versus the rural. And in fact, we did the same intervention in the rural areas. And yes, the population is there. When you move to these areas, leave alone what you see here, Kololo, the people are there. And then the markets, they're in the arcades, and they are busy. They're either selling food, they don't have time really to come here. And I think that's why the KCC office really directed us to find them in the community, because their argument was these people only come here if it's an emergency. They won't come here for FP because it's not an emergency. So yes, even 5,000, you can get even more. Because recently we were in Kamocha and we had over 100 women just in one day. We are working with Rotary. And they were saying the nearest facility is Bukoto and it's far. They can't leave their places. So such interventions really bring services closer, and that's when you know that you have the women. About the injection safety, yes, like I said, we have the quality control, the quality improvement department, but also as we're working with the VHTs, we have encouraged them to, these Vaseline tins, to drop those needles into those tins. If you drop it in, it won't have access out. And then as they come for these review meetings, they bring those, and then the health worker takes over to ensure quality. And that's the same that we tell the mothers to do. If you're coming back for a refill, if you got 3 or 2 vials, you have to come back with that tin, with that for safety even at home. About stock, I think this one we shall direct it to MOH because stock has been an issue. But when we're implementing, we had some of the learnings. We have had partners like FPA that we learned from and that have supported us so much with stock. But also some of those learnings we brought, we've been able to work with the medicine team at KCCA to ensure that we have this. The biggest problem has been with documentation and quantification. We realized that some of these facilities, either they don't count what the VHT has taken. They only count what is in what has been provided at the facility. So when it comes to providing the stock, they give them. So that's one of the things that we have ensured that we do. All the data that comes from the VHT is captured in the FP register, but also as we are quantifying, we put into account the stock that is given to the VHT. Another was about male involvement.
Wind up.
Yeah, that's the last one, Chair. Yes, another was about male involvement. We know male involvement is a big issue. We have tried to have different interventions above the line, digital, below the line. We've used influencers, radio, to ensure that we pass on this information. But also as a result of this, I know in Kampala it hasn't been so much. We've not got a lot of issues, but where we are implementing outside Kampala, we saw that there are lots of such issues, GBV, as a result of not involving men, and we are emphasizing that. We've also started another project called Maverick that focuses on men, and we're trying to understand men, but also to see how they get information on FP to support their partners. The last one was really about the indicator of methods. Yes, that was one of the indicators to ensure that people get FP services, but we also saw, because we do sample calls like I mentioned, and then we also did an adaptive learning where we had a survey and tried to get perspectives of the clients on how they feel. Unfortunately, this presentation wasn't about that, but it's a good topic to write about next time. Thank you very much.
Okay, Kavale.
Thank you so much. I got two questions. The first one is about budget allocation. And I want to say that there is no very specific budget for 5As, but there is, at the beginning of every financial year, every unit does make a work plan. This work plan, in the work plan, they put whatever they want as a unit or they want to do as a unit, and then the hospital will prioritize and look at what can we give these people, and in the end, you find along with everything, 5S QI is being covered. When we got G to G, we also put in our work plan, and still they allocated a small fund for QI 5S, and so it has been helping along with the hospital. So basically it's looking here and there, and it's a matter of like the leadership being involved and giving you giving it a priority, and that's how it works. Thank you. Then the next question is about 5S assessments. As Kaba Regional Referral Hospital, we do them every month, and these results, we compile them and share them again during QI meetings. And we have the tools that we use, so if you need, you can reach out to me and we shall share them. But the teams that have always come for benchmarking, we've always shared the tools. But if you don't have, still you can reach out to me. So in these assessments, we still set targets and make sure that each unit is reaching that target. So our current target is around 80%. As we compile, so we look at how each unit has performed, and then we share whether they have performed lower or higher, depending. We share and learn from each other as units.
Thank you. So Kabale Regional Referral Hospital is available, is open for benchmarking. Jennifer, you received quite many. I expect you to be a bit quick.
And I'm grateful that I received many because of the timing, but also they paid attention. So maybe I first start off by introducing myself. It will probably clear a number of things. So my name is Jennifer Dong. I work with USAID Uganda Health Activity as a technical advisor for child and adolescent health, doubling as a One Health focal person for Acholi. So I want to start with the objective. We did more of a wide, so we could have a wider result area. That's why we said we want to boost immunization rates, at which we will be looking at coverage, utilization, and put into it issues of zero dose and dropout rates. So with that, we would monitor a number of things being an above site activity, so we can address them concurrently. The measure for fully immunized by Ministry of Health standard right now that we know is still MR1, just like access and utilization is still at 90%, and yet the recommendation has gone to 95%. So we are still using MR1, but nevertheless, as a region, we're already monitoring the improvement of MR2. So we have had, with the same period, we've had a 10% gain in MR2 coverage from 4% to 14%, but particularly Agago is performing above the regional level at 16% coverage for MR2. So this is still work in progress, just like we're also still working in progress to improve access and utilization of immunization services in the region. Fluctuating dropout rates, This, we all know that dropout rates are highly dependent on the microplans, or maybe we don't know. The microplans actually help you to identify the communities that come to that particular facility so that you divert. So we don't entirely depend on the population, a catchment population of the facility, but the access to the services, to the EPI services in that facility. So dropout rates will continue to fluctuate because our microplanning is still poor, and we're working on improving that. We've only had one good, fairly good microplanning in the last financial year, that is September of last year. The other two are really recommendations. That's capacity building for the districts to come and now start presenting, and that is work in progress. I told you EPI was like one of the neglected diseases in the region. So building confidence starts slowly. I bet by the next QI conference we'll have district-led presentations here on EPI. But also, I really recommended that performance reviews should include EPI services. It shouldn't stand alone. It is one thing that is always left out. But now we want to see that as you do performance of a district, of a region, we see immunization coverage coming through, the dropout rates coming through, and so we can use that platform to educate persons and build capacity accordingly as we identify the gaps. I think basically those are it. Thank you.
Thank you. A round of applause for the presenters. So you can step down. Oh, okay. So I think I want to end my session, Chair. Allow me hand over to Basaja Tevadiba. That's the name I got. Yeah, it's a unique one, eh? So. Okay, and I also want you to thank me for chairing the session. You will do that? Okay, fine. Thank you. Thank you.
Thank you so much, Alphonse, who has chaired this session. You see, wanted to be appreciated, but I had wanted it to do it in a grand manner. So can we give him a big, big clap in appreciation? Another big, big thunderous clap to the presenters. Yeah, thank you for this presentation. Now there were some online questions, and I wanted them to project so that what we are going to do, Nolan, you will go and respond in the chat after the session. You're not going to use audio. So apologies to our online colleagues. So she's going to give a response in the chat, then project the next one. The next one was for Nansang Amole. It was going appreciating Edgar, because all this was just a compliment. No, there's a question also. What were the seroconversion rates like? That is, how many mothers had a change in serostatus across the retesting periods? So you also go and respond it in the chat during the break tea. I think the third one was a comment. I would project to that. Okay, the other one was a comment. So those are the things which you need to do. And like we said, the time here is not adequate enough, but we can always interact with these presenters as doing lunch, break, and so forth. So that's it from the MC side. Now the other point is lunch. We are going for lunch. The time is?
It's now 2:30.
It's 2:30, so lunch is going to be for 30 minutes. We come back at 3 for poster presentations for 20 minutes, and then at 3:20 we resume the breakout sessions. So thank you so much. You can go for lunch. So I also request the presenters in the different breakout sessions, please you take your meals faster, and the same applies to the presenters at the posters. So thank you so much, bon appetit, and see you at 3.
Thank you.
Over 5.